Good evening, friends. Today our guest speaker is Dr. Nelson Leong from Mayo Clinic, Rochester. He will be lecturing us on monoclonal gammopathy of renal significance. This webinar is brought to you by Mumbai Hematology Group, supported by ADLI and managed by Mice Ideas. I thank Mr. Ashutosh Shukla and their team from ADLI, Rajesh Kalpesh and their team from Mice Ideas, Executive Committee of Mumbai Hematology Group. Our guest speaker for the day, Dr. Nelson Leong from Mayo Clinic, Rochester. All our discussants were themselves eminent hematologists, medical oncologists, or nephrologists, and you participants for sparing your Saturday evening. Just to remind you, tomorrow morning at 11:30 a.m., we have Dr. Antonio Piga from Torino University, Italy, speaking to us on fertility and bone disease in thalassemia. Our discussants today include a large number of galaxy of hematologists and oncologists from Pune, Mumbai, Bangalore, Lucknow, Bhubaneswar, Ludhiana, Kolkata, Delhi, and Hyderabad. We have Lieutenant Colonel Dr. Uday Yanamandra from AFMC Pune, Dr. Aniket Mohite from Jahangir Hospital, Pune, Dr. Darshana Rane from Nanavati Hospital, Mumbai, Dr. Shilpa Gupta from Holy Spirit Hospital, Mumbai, Dr. Shilpa Prabhu from Majumdar Shah Medical Center, Bangalore, Dr. Vinu Sarathi from Bangalore Baptist Hospital, Bangalore, Dr. Dipankar Bhattacharya from Medanta Hospital, Lucknow, Dr. Saurabh Kumar Misra from Apollo Center, Bhubaneswar, Dr. Akshay Lahoti from Bhubaneswar, All India Institute, Dr. Rintu Sharma from Dayanand Medical College and Hospital, Ludhiana, Dr. Kunal Goyal from Institute of Hematology and Transfusion Medicine, Medical College, Kolkata, Dr. Sindhu Chitikela from Department of Medical Oncology, AIIMS, Delhi, Dr. Banda Ravi Teja from Nizams, Hyderabad. And now to introduce our guest speaker for the day, Dr. Nelson Leong. He is Professor of Medicine at Mayo Clinic, Rochester, is consultant in Division of Nephrology and Hematology from Department of Internal Medicine. His main interest is kidney diseases caused by monoclonal gammopathies. His focused areas of research include MGRS, myeloma kidney, renal response in patients with AL amyloidosis, etc. His founding member, International Kidney and Monoclonal Gammopathy Research Group. He did BS Combined Sciences from Santa Clara University, MD from University School of Medicine, internship from University of Iowa, residency and fellowship in nephrology from Mayo Clinic School of Medicine, Rochester. He is a recipient of Laurent Award in 2012 and Teacher of the Year Award in 2013. He organized KMG satellite meeting of the 14th International Symposium Amyloidosis 2014 and co-organized collaborative management of multi-system diseases, new developments and treatment strategies in 2014. He's published over 500 peer-reviewed articles in prestigious journals. I invite him to deliver the lecture on monoclonal gammopathy of renal significance. Thank you.
Dr. Agarwal, thank you very much for that great introduction. And I want to thank everyone for joining this seminar. I know it's late there in Mumbai. I guess I should share my screen then?
Yes, sir.
Okay. Can you see my slides now?
Yes, sir.
Okay, great. Well, thank you very much again. It's wonderful for me to be here and talking to all of you about MGRS. Here are my disclosures. So I think all of you are well aware that the kidney is an end organ target of many hematologic malignancies. In patients with multiple myeloma, 15 to 20% of the patients will present with acute kidney injury, depending on the definition. And approximately 12% of these patients will require dialysis. At autopsy, over 50% of the patients will have a pathology in the kidney that is associated with the multiple myeloma. Now, it's a little bit less common in Waldenström macroglobulinemia, but as you can see, approximately 20% of the patients will present with an eGFR of less than 60. And in patients with chronic lymphocytic leukemia, again, over 50% of the patients will have renal involvement on autopsy series. However, we and probably you as well, many hematologists and nephrologists have noticed that the kidney diseases are not restricted to those who have multiple myeloma. So this is a study out of Italy, over 1,300 patients, looking at the kidney biopsies of patients with various types of hematologic disorders. You see there's patients with MGUS, multiple myeloma, non-Hodgkin's lymphoma, smoldering multiple myeloma. What you see is definitely patients with multiple myeloma, non-Hodgkin's lymphoma, definitely have a lot of kidney diseases that are associated with the monoclonal protein. But as you can see, patients with MGUS also have a significant number of patients that have renal pathology associated with the monoclonal protein. And in fact, if you look, patients with MGUS actually make up the highest proportion of patients in this study. So while the percentage is less, the absolute number is actually quite high. And I just want to go over a case with you. This is one of the first cases that got me thinking about this. This was a patient from Canada. He was a Royal Canadian Mounted Police. And he came to me with a 2-year history of arthralgia, fatigue, a vasculitic rash that was biopsied and was suggestive of cryoglobulinemia. But cryoglobulins were negative on multiple occasions. He presented again in February, and this time he had shortness of breath. He was in acute renal failure. Creatinine was 4.1, which is about 380 micromoles per liter. And a kidney biopsy was obtained. So this is what his kidney biopsy showed. And for those of you who are not very familiar with kidney biopsy, this is a very abnormal glomerulus. You see that this is very proliferative. We don't see a lot of open capillaries, which is what we would normally see in a healthy glomerulus. But more importantly, you see these thrombi in the capillary loops. These thrombi stain for capital light chain, but not lambda. And on higher power light microscopy, you see that these form kind of a crystalline structure, occluding the vessels. And on electron microscopy, you see that this is definitely, this definitely has a paracrystalline structure. And in fact, this measures out to be about 20 nanometer in periodicity. So this is a patient with a crystalline IgG kappa thrombi deposit in the kidney. Now, at the time, as pathologists called this glomerulopathy of monoclonal gammopathy of undetermined significance. And we'll go over this term, why this term is important in a little bit. In any case, they repeated the cryoglobulins. They were again negative. Serum protein electrophoresis was negative, and this patient was treated with high-dose steroids, and the kidney function did improve a little bit. Creatinine went down to 1.9. But 2 years later, again in February, this patient presented with sudden dark urine and then became anuric. And on angiogram, you see that a lot of the peripheral vessel in the kidneys are all completely occluded. They tried to give this patient thrombolytic, but no response, and the patient became dialysis dependent. At the time, his hemoglobin was normal, his platelet count was low, and his creatinine was 8.2. He had a very high LDH. C3 was slightly low, but C4 was normal, and cryoglobulins, again, were negative. He came to the Mayo Clinic, and we repeated some labs. Again, cryoglobulins were negative, but on immunofixation now, we detected a small monoclonal IgG kappa. And remember that this is the same monoclonal protein that was detected in the kidney. The M spike actually is measurable at 0.4 grams per deciliter. We did a bone marrow biopsy, which showed 1% plasma cell, and bone survey at the time showed no lytic lesion. So the question is, what was the diagnosis? Was it glomerulopathy of monoclonal gammopathy of undetermined significance, as the renal pathologist had suggested? Was it monoclonal gammopathy of undetermined significance, or MGUS? Was it multiple myeloma, or was it something else? So if we look at the International Myeloma Working Group's definition, we see that they have a definition for plasma cell disorder that's broken down into 3 parts. One is what the tumor burden is in the bone marrow. 2 is an organ damage known by the acronym CRAB. And then in 2014, 3 biomarkers were added. These were free light chain ratio greater than 100, bone marrow plasma cells greater than 60%, and more than 1 bone lesion on MRI. Now, if we go back to look at this patient, definitely this patient did not meet multiple myeloma criteria. His bone marrow biopsy only showed 1% plasma cell. When he presented at the time, we did not have the free light chain assay, so we don't know what it was. He did have renal impairment, but in 2014, the IMWG defined renal impairment as that of CAS nephropathy only. So he did not have CAS nephropathy. Now, one of the reasons why the term was significant in that the renal pathologist named this glomerulopathy of monoclonal gammopathy of undetermined significance is that under the IMWG and other hematologic organizations, patients with MGUS should not undergo treatment. They should be observed. Those with smoldering myeloma should be observed or undergo clinical trial. And only those with multiple myeloma should be treated. So that gives us a dilemma, because here's a patient that has a kidney disease, which appears to be related to the monoclonal protein that he's producing, but we cannot treat them. And that's the problem that was created at the time that was becoming increasingly recognized. We have these diseases that we have no diagnostic name for them. And what this presented was that we can't make an accurate diagnosis. Physician to physician, we cannot convey what the patient has, and we can't tell the patients what they have either. More importantly, though, without a diagnosis, there's no ICD code. ICD codes are derived from WHO. And if WHO doesn't recognize the disease, there's no ICD codes. And in the United States, ICD codes are everything, because we cannot bill for them. We can't get treatment for the patients if there's no ICD code for that disease. And finally, we can't do any research, because if there's no consensus on the names, people will call things differently, and you can't create confusions. And you can't get a grant from any organization if you can't tell them what you're studying. And these are just some examples. So this is a paper out of Italy in patients with light chain deposition disease. And the authors in this paper divided up the patients into 3 categories: those with multiple myeloma, those with lymphoproliferative disorders, and then there's this idiopathic group which made up over a third of the patients. From the definition in this paper, the idiopathic group did not meet definition for multiple myeloma or lymphoproliferative disorders. But take a look at the difference in terms of treatment of these patients. First of all, fewer patients that did not meet multiple myeloma definition were treated, although it didn't make statistical significance. But if you look at the patients that were treated, what chemotherapy they received, you see that the patients were much more likely to receive chemotherapy for multiple myeloma of the day if they had multiple myeloma than if they did not. So most of the patients who did not just receive corticosteroids and alkylating agents. And this is not unique. When Dr. Kyle coined the term monoclonal gammopathy of undetermined significance, it was because that a lot of these terms were coming out, which actually did not describe the nature of the disease. These terms were benign, asymptomatic, idiopathic, which we saw before, discrete, cryptogenic. They really didn't describe what the natural disease was, and that was that these were precancerous condition that can progress to a malignant state, but at the time that you made the diagnosis, these patients did not meet criteria. And that's why Dr. Kyle came up with the term monoclonal gammopathy of undetermined significance, where the significance is determined over time. Now, this issue isn't unique to plasma cell disorders. So if we look at patients with CLL, you see that treatment for CLL is not recommended until CLL reach a more advanced stage, such as RISE stage 2 or Benet stage B or C. Now, there is one statement in the entire consensus guideline that says that symptomatic or functional extranodal involvement, which includes the kidney, could be treated. But there was no definition on what that meant. Is that bulky disease? Is that an elevated creatinine? There's just no definition for that. And for Waldenström macroglobulinemia, it's even worse. There's actually no renal criteria for initiating treatment. So recognizing this, the International Kidney and Monoclonal Gammopathy Research Group came up with the term monoclonal gammopathy of renal significance. And we wanted to make this term independent of monoclonal gammopathy of undetermined significance because we didn't want the confusion that these diseases should not be treated. And in fact, what MGRS does is that it doesn't replace the current IMWG guidelines, but it supplements it so that patients with a monoclonal disorder who produces a nephrotoxic light chain can be categorized as having MGRS. And the renal impairment is everything but CAS nephropathy because CAS nephropathy is now a myeloma defining event. So if they have any lesions associated with monoclonal gammopathy, they can be categorized as having MGRS. Now, this fits with what's known in the animal data, and that is that cells are not required to produce the renal lesion, just a monoclonal protein. This is a study done by Alan Solomon over 30 years ago now, where he took urine of patients with these disorders, purified the protein and injected them into mice. And what he was able to do was reproduce the lesion exactly in the mouse. So in this case, this is a CAS nephropathy. These are light chain crystals and light chain proximal tubulopathy, tubular basement membrane deposits in MIDD or monoclonal immunoglobulin deposition disease, and then finally Congo red deposits in amyloidosis. So now I'd like to go over the characteristics of MGRS-related diseases. There are 4 characteristics that have been identified. First of all, these kidney diseases are progressive. So as you can see on the top right chart, this is patients with membranous nephropathy, a common immunoglobulin mediated kidney disease. And majority of the patients, they actually do quite well. The patients in the top line, A, these patients undergo spontaneous remission, whereas B, they have relatively stable disease. And only in patients who have more severe proteinuria do their disease progress. However, if you look at the bottom two graph of patients with AL amyloidosis and light chain deposition disease, you see that all of these patients progress over time. Response to immunosuppression is also poor. So while we use immunosuppression to treat non-monoclonal immunoglobulin-related kidney diseases, patients with MGRS typically do not respond to immunosuppression. And this is illustrated by a study out of France where patients with C3 glomerulopathy with monoclonal gammopathy was treated, and the retrospective study looking at the response to treatment. As you can see, the patients with the red line treated with chemotherapy did the best, whereas patients treated with low-dose immunosuppressive therapy and conservative treatment with renin-angiotensin blockade did quite poorly. And the reason for this is this. So only patients who were treated with chemotherapy were able to achieve a deep hematologic response. And it is this deep hematologic response that is associated with the renal response. In fact, on the graph on the right, you see that patients who were treated with chemotherapy but did not achieve a VGPR actually continued to progress, just like patients who were treated with low-dose immunosuppressive therapy, which was steroid and low-dose alkylator, and conservative treatment. The third characteristic is that these patients have a high rate of recurrence after kidney transplantation. This is just one example. So these are patients with proliferative glomerulonephritis with monoclonal immunoglobulin deposition, PGN-MID. And as you can see, the recurrence rate was around 90%. And many of these patients recurred quite early after transplant. In fact, 70% of these patients recurred within the first year of transplantation. Many of them end up losing their graft. And in fact, a more recent study out of the Mayo Clinic of other patients with MGRS all showed the same characteristics. Finally, like MGUS, some of these patients will progress to a malignant condition. So how often do we find patients with MGRS? This is a patient, or this is a study out of the Mayo Clinic looking at patients who have monoclonal gammopathy, but patients with multiple myeloma and lymphomas were excluded. And in this study, of the patients who underwent kidney biopsy, 40% of those patients actually had an MGRS-related lesion. Three characteristics were identified that were associated with MGRS. These are proteinuria greater than 1.5 gram per day, hematuria, and an abnormal free light chain ratio. And if we look at how often this occurred, going back to the study, over 1,800 patients were included in the study. And of those who did not have labs at the time of biopsy, we had 1,600 patients going into the study. But 37% of these patients had kidney disease as defined by having an abnormal creatinine or proteinuria. Of these almost 600 patients, 10% underwent a kidney biopsy, and that's where the 40% of the MGRS came from. And it turns out that approximately 1.5% of the patients who had monoclonal gammopathy had an MGRS lesion, which interestingly is very close to another study out of Europe. Now, while there are many differences in the pathologic characteristics of the MGRS lesions, there are also hematologic differences. First of all, as you can see in this chart, MGRS actually makes up majority of the cases in many of these lesions. For example, in patients with AL amyloidosis, type 1 cryoglobulinemia, light chain proximal tubulopathy, MIDD, PGN-MID, actually in nearly all of these, MGRS is actually the most common hematologic cause, whereas multiple myeloma and lymphomas actually is the minority. The only exception is patients with immunotactoid glomerulonephritis, where many of these patients have a CLL clone, but many of those also are just classified as monoclonal B-cell lymphoproliferative disorder rather than full CLL. On the kidney biopsy, it's important to note that there are three characteristics on immunofluorescence, and it is very important that we ask the pathologist to look at this before we initiate treatment. In fact, just this month, I saw a patient who undergone treatment with Daracibor-D and actually did not have an MGRS lesion. So it's very important to work with your renal pathologist to get the diagnosis correctly. First of all, the most common immunofluorescence characteristic is that you stain for a monoclonal immunoglobulin. And what that means is that the monoclonal immunoglobulin should stain for only one light chain. Now, having the heavy chain stain is additive, but not diagnostic. The other pattern is no immunoglobulin staining, but you stain for C3. This is the characteristic in patients with C3 glomerulopathy with monoclonal gammopathy. And then finally, no immune deposits whatsoever, no immunoglobulin, no C3. And this is seen in patients with thrombotic microangiopathy. And again, the definition for monotypic or monoclonal immunoglobulin is that the light chain has to be restricted. Now, heavy chain restriction can be helpful, but there are polyclonal immunoglobulin diseases that are heavy chain restricted, but not light chain restricted. The only time that heavy chain restriction can be taken as a definition for MGRS is in heavy chain diseases such as heavy chain amyloidosis and heavy chain deposition disease, where there's no light chain whatsoever. So these are the common lesions that are that have been identified by the IKMG as being associated with MGRS. These can be separated into several categories. First of all, in the categories where immunoglobulin deposits are there, they can be organized into whether they have organized deposits on electron microscopy or non-organized deposits. The organized deposits are represented by the immunoglobulin amyloidosis, immunotactoid glomerulonephritis, cryoglobulinemia type 1 or type 2, or some type 2, crystal storing histiocytosis, cryoglobulinemia, and the non-organized deposits are represented by MIDD, MPG, and MID. In the complement deposits, this is the C3 glomerulopathy with monoclonal gammopathy. And then no deposits are thrombotic microangiopathy associated with monoclonal immunoglobulins. Here, I'm going to present some data showing you the importance of VGPR. So this is a study out of the UK looking at patients with light chain deposition disease. And as you can see, again, achieving a VGPR is very important in these patients, as only patients who achieved the VGPR or better were able to preserve their kidney function, while all the patients who had PR or less progress in their kidney disease. And in fact, only patients with VGPR or better had improvement in their kidney function. Now, in this study, they found that not all novel agents had the same responses. In fact, bortezomib-based therapy and patients treated with autologous stem cell transplantation were able to achieve deeper responses than those who were achieved by low-dose alkylators or IMiDs. And in fact, in this study, if the patients did not achieve a VGPR or better, they can be consolidated with a transplant. These results were replicated by the Boston University group, where again, they showed that patients who were treated with autologous stem cell transplantation or bortezomib had a higher rate of VGPR and CR, whereas those treated with other agents were more likely to achieve a PR. In addition to the hematologic response, the baseline kidney function is also very important. This is another study of patients with monoclonal immunoglobulin deposition disease. And again, you see that the patients who achieved the VGPR or better had the best renal outcome, but only in those patients that started with a baseline eGFR of greater than 20. In patients who had a baseline eGFR of less than 20, many of them will progress regardless of the hematologic response. And this is because in the kidney, there is a point of no return where at some point, the damage is just too much to recover, no matter what the hematologic response is. Another thing that I want to point out is the duration of treatment. In multiple myeloma these days, it is standard to have patients undergo induction therapy, followed by stem cell transplant, followed by consolidation, then maintenance therapy that can be indefinite. However, since these patients do not have a malignant condition, shorter duration of therapy may be effective. And in fact, this is what it was shown in two studies, one from France and one from Greece, where these patients undergo a median cycle of therapy of 5 and were able to achieve very good responses. In the French study, patients who achieve a VGPR or better with bortezomib had a median time to progression of almost 9 years. In the Mayo Clinic study, time to hematologic progression was significantly different between patients who achieved a VGPR or better, which was 55 months versus 23 months for those who had less than a VGPR. So again, short courses of therapy may be sufficient for these patients, and maintenance therapy is usually not required unless the patient has a history of relapse. So with these, the IKMG devised this treatment algorithm. So in patients who had a positive kidney biopsy, the patient should be evaluated for multiple myeloma, Waldenstrom, CLL, and other non-Hodgkin's lymphoma. If they have those, they should undergo standard treatment or clinical trial. They should also undergo evaluation for AL amyloidosis. And if they have those, they should undergo consensus treatment or clinical trial as well. Now, those patients who do not have any of these conditions, then we evaluate to see if they have advanced CKD or end-stage renal disease. If they do not, then they should undergo clone-directed therapy. If they do, they should be evaluated to see if they're transplant recipients. If they are kidney transplant recipients, they should undergo clone-directed therapy before their kidney transplant to prevent recurrence. And if they're not kidney transplant candidates and they have advanced CKD or end-stage renal disease already, then they should be observed until they progress hematologically. One thing that I do want to talk about is patients with PGN-MID. Now, we've been talking about clone-directed therapy, but in PGN-MID, unfortunately, very few patients actually have identifiable clones. In fact, even the monoclonal protein is difficult to identify. In this study out of the Mayo Clinic of 60 patients, only about 20% of the patients had an identifiable monoclonal protein circulating outside the kidney. And in these patients, the patients that have a positive immunofixation and abnormal serum free light chain, we were able to identify clone in most of these patients. Whereas if the immunofixation was negative, then clonal detection rate dropped dramatically. 17% in those that are negative for immunofixation but abnormal free light chain ratio, and 0% in those who were negative in both. Now, in the patients that we did identify a clone, 50% of them were plasma cell in origin, and 50% expressed CD20. In those that express CD20, approximately half of those co-express CD38, suggesting they are lymphoplasmacytic lymphoma clones. These results were actually replicated at University of Pennsylvania, where again, they showed that in patients that they were able to identify a clone, 50% were plasma cell in origin and 50% were CD20 positive, with 1/3 being CD20 and CD38 co-positive. The importance of this study is that it showed how important it is to have clone-directed therapy. In the green box, these patients underwent clone-directed therapy, and as you can see, the renal response rate or complete response in 3/4 of these patients, whereas in the red box, these patients did not undergo clone-directed therapy, and the response rate was very low. What's more important is that in the patients that did not have an identifiable clone, the renal response was about 50%, as you can imagine, because we can only guess at what clone to target with the clone-directed therapy. Now, one bit of good news is that a pilot study was performed at the Mayo Clinic in patients with PGN-MID with no identifiable clone. This was done with single-agent daratumumab, and what you see is that the renal response rate were actually quite good. 3 patients had a complete response, which was defined as proteinuria going below 500 milligrams per day. Partial response, which was defined by 50% reduction in the proteinuria, and 1 patient had no response. So this is certainly very encouraging data that daratumumab might be quite effective in these patients, and this definitely deserves further studies. And in fact, daratumumab has already been studied in other diseases. This is a study out of Athens using daratumumab either as single agent or in combination in patients with light chain deposition disease, C3 glomerulopathy, and 1 patient with PGN-MID. As you can see, the hematologic response was quite good in these patients. What they found, though, was that daratumumab in combination was more effective at achieving VGPR or better than daratumumab single agent or monotherapy. And this is shown in the Andromeda trial, where subcutaneous daratumumab was added to CyBorD in patients with AL amyloidosis. And as you can see, the combination therapy achieved an overall response rate of 96%, with 82% being VGPR or better. These response rates are nearly double those of CyBorD alone. And what's important about this is that with these excellent hematologic response rates, these patients had unprecedented organ response rates, 53% in the heart, 83% in the kidney, and 50% in the liver. And this is accomplished by a remarkable and rapid reduction of the serum free light chain. Daratumumab, when added to CyBorD, as I said, increased the VGPR rate by almost 2-fold, and it achieved a CR rate more than 1 cycle earlier than those treated with CyBorD alone. And as a result of these impressive results, the FDA actually approved subcutaneous daratumumab with CyBorD as the first treatment for AL amyloidosis. And I'm sure there's more to come. With the final few some other diseases. Monoclonal gammopathy of renal significance is actually a part of a larger disease group called monoclonal gammopathy of clinical significance. These include dermopathies, neuropathy, ocular diseases, as well as systemic diseases. And actually, my slides are slightly out of order, but I'll go back to this in a few minutes. I do want to go over a case with you, though, of MGRS and show you what some new development will help us in forms of diagnosis. This is a patient that I saw back in 2008. He developed Guillain-Barré syndrome after a viral illness and had motor and sensory neuropathy to above the knee. And then in 2010, he felt very poorly one day. It was right before Christmas. He remembered he was about to go to a Christmas party, but couldn't make it and went to the emergency department instead. He was very hypertensive and was found to be renal failure with creatinine of 4.3. He had no rash or arthralgia. He underwent a kidney biopsy, which showed this membranous proliferative glomerulonephritis with pseudothrombi. On immunofluorescence, it showed IgM 1 to 2 plus, C1q 4 plus, but there was no IgG, no IgA, and kappa and lambda were all negative. On laboratory evaluation, he was found to have a cryoglobulin, and the serum protein electrophoresis showed a small IgG lambda. He had 7 grams of proteinuria. C3 and C4 were low. The other serologies were all negative. Bone marrow biopsy showed 5% plasma cells with lambda predominance. So for some reason, he was given the diagnosis of type 2 cryoglobulinemia, probably because of the IgM presence in the kidney. So he was treated with Cytoxan prednisone, and actually he responded. Creatinine normalized, but the M spike actually did not change very much, and his neuropathy symptoms actually was a little bit better. Then 2 years later, he had a relapse. His hypertension recurred, creatinine climbed again, and this time he was treated with rituximab. He was actually treated with 2 courses, one in October and another in February. But this time there was no response. His creatinine actually continued to climb. Proteinuria was at 4.5 grams. Again, M spike didn't change. In fact, it was a little bit higher. And C4 and C3 were both still low. Again, for some reason, his neuropathy got a little bit better. Now, we know that there are 3 types of cryoglobulinemia and 2 types that are associated with monoclonal protein. Type 2 can be associated with monoclonal protein and hematologic disorder. These are mainly monoclonal IgM that target polyclonal IgG, causing a mixed cryoglobulinemia. And this is most commonly produced by B-cell proliferative disorder and LPL clones. And of course, the treatment would be rituximab, but this patient did not respond. Now, there's type 1 cryoglobulinemia, which can be type IgG, IgA, and actually sometimes IgM as well. With the IgG and IgA variant, plasma cells are the more common clonal origin, and these should be treated with anti-plasma cell therapy. So what type of cryoglobulin does this patient have? So we went back to the original kidney biopsy and we did a technique called pronase antigen retrieval, where we did some digestion on the kidney tissue and then redid the immunofluorescence stain. And what we found was that when we did pronase antigen retrieval, IgM was not present, but IgG and lambda became positive. Remember that he had an IgG lambda in the serum, and he had lambda light chain restricted plasma cells in the bone marrow. So with this finding, we changed the diagnosis to type 1 cryoglobulinemia, and he received Cybor D and did quite well with that. Now, the new development that I want to talk to you about is the use of the heavy light antibody in renal pathology. The heavy light antibody is available now to use as a blood test looking for monoclonal protein, but we modified it and used it in renal pathology. The advantage is this: in conventional antibody, they detect IgG, IgA, IgM, kappa, and lambda all separately. However, with the heavy light antibody, we detect IgG, kappa, IgG, lambda separately from IgA, kappa, and IgA, lambda, and so on and so forth. So if you were to look at biopsies, the biopsy on the right is one of type 2 cryoglobulinemia. Now, with conventional immunofluorescent antibodies, you would stain for IgG, IgM, kappa, and lambda, but you don't know which one of these is monoclonal. You infer it if you have the typing of the cryoglobulin to show you that it's a monoclonal IgM and polyclonal IgG, but you actually don't know from the kidney biopsy. By using heavy light immunofluorescence, though, you see that only IgM kappa is positive, IgM lambda is negative, whereas IgG kappa and lambda are both positive. So this really suggests that this is an monoclonal IgM kappa against polyclonal IgG in type 2 cryoglobulinemia. Now, going back to the monoclonal gammopathy of clinical significance, I'm just going to show you a few examples. This is scleromyxedema. This is a skin condition which is associated with low-grade plasma cell disorders. These patients typically do not meet criteria for multiple myeloma, and they present with these dense, almost purplish plaque in their skin. These plaques can be quite painful, and as you can see in this patient, treatment with thalidomide improved the condition significantly. This is a patient who developed calciphylaxis in POEM as a result of POEMS syndrome, I'm sorry. As you know, POEMS is a condition which is characterized by polyneuropathy, organomegaly, endocrinopathy, monoclonal protein, and skin changes. Now, the skin changes is typically not calciphylaxis. This is a very rare presentation. And it's rare because calciphylaxis is a skin condition that is seen in patients with end-stage renal disease, but this patient had normal kidney function when the calciphylaxis occurred, and we think is secondary to the POEMS syndrome. Others have been reported in the literature as well. In addition to skin, the eyes can become involved. This is crystalline keratopathy in patients with crystal storing histiocytosis. I don't know if it's projecting well, but you can actually see crystalline deposits in the retina itself. Seen mostly in crystal storing histiocytosis, but you can also see it in patients with light chain proximal tubulopathy. And then finally, this is Tempe syndrome. Tempe syndrome stands for telangiectasia, erythrocytosis secondary to endogenous erythropoietin, monoclonal protein, perinephric fluid collection, and these patients have typically a lambda light chain monoclonal gammopathy. And in this patient that was treated with bortezomib, you see that the telangiectasia went away, as well as the perinephric fluid collection. So I just want to introduce you to this concept of monoclonal gammopathy of clinical significance, is that they actually represents the bigger group of diseases caused by monoclonal gammopathy that do not meet criteria for multiple myeloma. And with that, I will end and take any questions. Thank you very much for your attention.
Thank you, sir. Dr. Nelson, you really opened our eyes. You presented your lifetime work. You were instrumental in coining this term, monoclonal gammopathy of renal significance and the clinical significance. And you took us over the last 15, 20 years of your journey so beautifully. Everything was made very clear. And I think we have registration of more than 400 delegates from 15 countries. All of them have benefited tremendously. And I think you opened their eyes with what this concept of MGRS and of clinical significance are. We have some of our Indian colleagues here who will like to ask you some question. We are going to use the raise hand sign. We start with Dr. Dipankar. Maybe one question at a time so everybody gets an opportunity.
So thank you, sir, for this excellent talk. My question would be, what would be the approach to a case of like mild renal dysfunction, like creatinine between 1 and 2, and a M protein like 1 to 1.5, like a low M spike with a mild elevation of free light chains, and only anemia as a presenting symptom without any other hypercalcemia or bone lesions? And what is the role of a bone marrow evaluation and a kidney biopsy in such cases?
Very good question. This obviously is the most common question I get asked. And that study I showed you from Clemjit out of the Mayo Clinic is one of the first studies that we're doing to try to answer that question. And I see that on the chat board, someone else kind of asked a similar question. So, actually, I gave an MGRS talk at the International Myeloma Working Group this year, and someone asked a similar question. If we add up all the percentages, MGRS patients would actually make up more than myeloma patients, and it would overwhelm the system. So how should we approach these patients? Well, I think that as you saw from the study, almost 40% of patients with MGUS have abnormal kidney function or have proteinuria. And so obviously we cannot work up everyone with that, because if you think about it, in patients that are over 50, 1% of 50-year-olds have an MGUS, and when they reach 70, 5% of patients have an MGUS. So that's a lot of patients to work up. And so we do definitely need some parameters to help us figure out who to do the workup. I think that the parameters in the Clemjit study was very helpful. Patients that have a proteinuria greater than 1.5 grams should be the ones that you really target. And those with abnormal free light chain ratio. Now, Dr. Clemjit's actually working on some other things. Interestingly, we all are concerned with patients with diabetes because they can present with proteinuria. And Dr. Clemjit is trying to work in diabetes into the model to see how it would affect the prevalence of those patients with MGRS. But the things that I go on is the proteinuria is obviously important, and the rate of decline in the kidney function. So as you see, the MGRS patients don't just stay stable, they tend to progress. And so if you have someone who is having increasing proteinuria over time that the nephrologist cannot control with blood pressure control, and they're losing kidney function, those are the patients that you really ought to consider doing a kidney biopsy and seeing if they have an MGRS lesion. Now, the issue with the kidney biopsy and bone marrow biopsy, which should be done first, this really depends on who you ask. If you ask the hematologist, they say that the kidney biopsy should be done first, because there's no point in doing the bone marrow biopsy unless we know that this is an MGRS. But if you ask the kidney doctors, for some reason, many of them will say to do the bone marrow first, which I think is actually the wrong order. I do think that the bone marrow biopsy should be performed based on clinical parameters that you normally use to get a bone marrow biopsy. I mean, we typically wouldn't do a bone marrow biopsy until the M spike is above 1 to 1.5, or if the free light chain ratio is highly abnormal, usually greater than 8, or they have significant anemia that's unexplained. So we wouldn't do a bone marrow biopsy unless they have that. But if they have an MGRS, obviously, then we should do a bone marrow biopsy. So I hope that answers your question.
Thank you, sir.
Thank you, Dipankar. Dr. Uday?
Sir, that was an excellent talk, and it was really great listening to you. Sir, many of the lymphomatous disorders also have monoclonal proteins. How do we proceed in a patient of lymphoma with monoclonal protein with renal dysfunction?
Yeah, as I showed you earlier, the lymphoma data showed that the kidney involvement is less, but they definitely have them. In fact, there are a couple of studies of patients with IgM monoclonal disorders where most of them have lymphoplasmacytic lymphoma, and they have a wide variety of renal disease, just like in plasma cell disorders. What I find is that most lymphoma patients, their kidney disorder is infiltration of the lymphoma into the kidney. In fact, in multiple autopsy series, even many of which came from India, they showed that anywhere from 60 to 80% of patients with lymphoma will have lymphoma involvement in the kidney. CLL is right up there. LPL is right up there. Now, these patients typically don't have a monoclonal protein. And what's more interesting is that most of these patients don't actually have renal impairment. They're found incidentally on autopsies. We looked at a population of CLL patients at Mayo, and less than 10% of them actually had abnormal kidney dysfunction, and very few undergo kidney biopsy. I think you use the same parameters that if a patient is losing kidney function rapidly or have high-grade proteinuria, those are the patients that you should work up. Going back a little bit, the patients that have lymphoma infiltration in the kidney, those patients will just present with acute kidney injury without proteinuria. They typically don't present with much proteinuria, but they will have elevated creatinine. And we don't actually know why, when 80% of the patients have lymphoma in the kidney, but only a single-digit percentage of them actually have kidney injury. Somehow the lymphoma may be different or have different characteristics that are injuring the tubules rather than just coexisting.
Thank you, sir. Dr. Saurav.
So, sir, if you may just forgive me for being naive, I would just like to ask a very basic question, because these are difficult topics for us. So my question is, so these patients who are having smoldering multiple myeloma, and if now they develop renal failure, so usually we would say that this is a multiple myeloma. So now, after listening to your talk, do you think that we should be doing a biopsy, renal biopsy in these patients to know whether it's a MGRS on a smoldering myeloma or it's a multiple myeloma? So I think that's my question.
Okay, so that's a very good question. And that question is becoming more convoluted by the year. And that's because the definition of smoldering myeloma is changing all the time. So in 2014, the IMWG added the 3 biomarkers, and all of a sudden, smoldering myelomas that have free light chain ratio greater than 100 and bone marrow plasma cell greater than 60% are no longer smoldering multiple myeloma. They are now considered multiple myeloma. And then, as you know, the concept of 20-20-20 is coming out. This is 20% plasma cells, 20% or 20
FLC.
I have to think milligram per liter of M spike, and then a ratio involved to uninvolved free light chain ratio of 20. This concept is coming out, and it will further reduce the number of patients that actually have smoldering multiple myeloma. And what these are telling us is that, remember that in smoldering multiple myeloma, the progression rate has 3 phases. The first is the first 5 years, which they progress at 10% per year for 5 years. And then they progress for 3% per year for the next 5 years. And then once you get to 10 years, their progression rate is only a little bit above MGUS, around 1 to 2%. And perhaps these different criteria are separating out those patients. The 3 biomarkers, the involved to uninvolved free light chain greater than 100 is, and the bone marrow biopsy greater than 60% are the ones that progress 10% per year. Actually, those criteria were selected because 60 to 80% of them progress in 2 years. The 20-20-20 are patients that 50% progress at 5 years, and those are probably the patients that are the next 5 years. And then once you eliminate those are really smoldering multiple myelomas that have very slow progression. Now, that's a long answer to your question, but basically, if you're going to treat anyway as a multiple myeloma, then you probably don't need the kidney biopsy unless the kidney function is not responding to your therapy. Then you want to figure out why you're not, why the kidney function is deteriorating. And I think that this is one of the key points, if I can impart this with you. And this is more important in patients with lymphomas. So in myeloma, we're very used to treating to CR, and now we're treating to MRD negativity. But in lymphoma, if the CLL is, reduced down and the lymphocytosis is under 5,000, people are pretty comfortable with that. Same thing with Waldenström macroglobulinemia. If we reduce the IgM down and they're no longer hyperviscous or their cryo goes away, we're pretty comfortable. We don't need to take them down to VGPR or a CR. Well, remember that the MGRS lesions continue to progress if they don't get to a very deep response. And so, if you're going to treat, and if it is an MGRS, you need a much deeper response than you would if you're just treating the hematologic disorder. I mean, I have patients, that I'm treating with multiple myeloma, and they've been in a PR for 2 years. I call it a truce. We have a truce with the myeloma. You don't progress, I don't intensify the treatment. But that doesn't, you can't do that with MGRS because as you saw study after study, if they're PR or less, the kidney disease will progress. And so by knowing that it is an MGRS, it changed the target or goal of your treatment, because you have, if you are going to try to save the kidneys, you may have to go deeper. I hope that answers your question.
Thank you. Thanks a lot. Thank you.
Sir. Dr. Rintu.
Thank you for the excellent lecture, sir. It is always a privilege to listen to you. I would just like to ask that how often and when do you use the paraffin immunofluorescence for unmasking the immunoglobulin deposits, the pronase antigen retrieval?
Sure. So we use it mostly in a few diseases. We don't typically need to use it in AL amyloidosis, and we typically don't need to use it in MIDD. Where we use it a lot is in C3 glomerulopathy, because a lot of times the regular immunofluorescence will just show us C3 when in fact there are mass immunoglobulin deposits in there. We use it a lot in light chain proximal tubulopathy. We think that when the light chain turns into the crystalline structure, it loses some of the epitopes and we don't get the staining that we need. So those are the ones that we use pronase a lot in. We're actually using pronase more and more in cases of suspected cryoglobulinemia.
Okay.
And it is exactly the reason that I showed you in that case where the regular immunofluorescent came up with something completely different. And when we use pronase digestion, we actually saw the real deposits in the kidney. And what I showed you with the heavy light, when we did the validation for that, we found that it is as sensitive as the pronase. So we're actually trying to do larger series studies to see which one is better. But both of these are immunofluorescence techniques so that most people can use these to make their diagnosis.
And sir, is there any importance of doing FISH on the renal tissue in these patients to detect like a high risk cytogenetics in these patients, because plasma cells in the marrow are very few? So is there any importance or relevance of doing FISH on the renal tissue in these patients?
So unfortunately, there are not a lot of plasma cells or lymphocytes there either. Now, having said that, I'm doing FISH on a patient right now that well, this patient is very unusual. He has a monoclonal B cell infiltrate in the kidney, but in the marrow, it's all plasma cell. So and they're both lambda light chain restricted. So we don't know if this patient had 2 clones or if he has 1 clone. And so now we're doing FISH to see if the FISH results are the same as the one in the bone marrow. So, but it's very uncommon that you find enough mononuclear cells in the kidney to actually do FISH. Most of the time, the cells are not in there either.
Thank you, sir.
Thank you, Dr. Rintu. Dr. Shilpa Gupta.
Good evening, sir. Excellent talk. My question is based on a very common clinical scenario that we come across as hemato-oncologists. So we have referred some patients of chronic kidney disease who are already on dialysis, and on retrospect, a nephrologist has seen some skewed kappa lambda ratio on immunofixation, or there is a very small M band. So they ask for a marrow, and when we do the marrow, we find that there is a minimal increase, less than 10% or sometimes 2 to 3% plasma cells, which are again polytypic, polyclonal. So my question is whether these patients, if they've already progressed to CKD, how do we come to know whether this is an MGRS, and how do we go about treating such patients? Do we give them the treatment of bortezomib based or IMiDs?
So that's a very good question. As you know, kidney failure itself causes a skewing of the free light chain ratio. However, that is only the case with the binding site assay. So that skewing doesn't occur, or at least the ratio doesn't become different in the N-latex assay. The Australian group have shown that while both kappa and lambda free light chain do go up with renal failure with the N-latex assay, the ratio doesn't change. So, so in the binding site assay, the ratio of the LAMP kappa goes from 1.65 to 3.1. The ratio stays the same with the N latex. So maybe getting a second free light chain test could be useful. If the second free light chain test, the ratio is the same, then you're probably not dealing with a clonal disorder. Now, your other question is someone who's already on dialysis or with advanced CKD, should they undergo treatment? And based on the algorithm, only if they are kidney transplant recipient or potential kidney transplant recipient should they undergo treatment. If they are not, then the organ's already gone, the organ that is damaged is already gone, then it really doesn't, there's no point in treating it. In fact, just this week we had two patients that are very similar. We have one patient who is already on dialysis, who has an MIDD, and he hates getting blood draws. He won't get blood draws. He doesn't like injections. And we said, if you don't like blood draw, it's very difficult to treat you. And how are you going to get a kidney transplant? And he said, well, if getting a kidney transplant means I have to have a lot of blood draws, I don't want one. And so when he said he doesn't want a kidney transplant, then we go, well, why are we treating you? Because your disease, you're not anemic, you don't have any bone disease. Then we would wait until you have hematologic progression before you would be treated. So if they were a kidney transplant candidate, then they should be treated, because as I showed you before, the recurrence rate is very high, and it can recur very quickly if their hematologic disease is not controlled before kidney transplantation. So only in patients that you think have a reasonable chance of recovering kidney function, so an eGFR greater than 20, or someone who is undergoing kidney transplant evaluation and have a good chance of getting a kidney transplant, then you should treat them.
Thank you.
Thank you, sir.
Thank you. Dr. Kunal.
Thank you, sir, for enlightening us with the concept of MGRS. My question to you is, I have 2 or 3 questions. My first question is, how do you monitor MGRS, and how often do you monitor them? And in certain cases where the clones are difficult to identify, in those cases, how do you diagnose them, and how do you manage? And third question is, in India, there is a resource constraint setting. Patients are not able to do biopsies, kidney biopsies and immunofluorescence. And if we are suspecting MGRS, then in that case, what should be the approach?
So your first 2 questions, so a lot of what we learned about MGRS came from treatment of patients with AL amyloidosis. AL amyloidosis is really the original MGRS disease. They have low clonal burden. Many of them, the kidney is the only organ involved. And remember that before free light chain came out, 20% of patients with AL amyloidosis did not have a monoclonal protein. And so we monitor, so when we treat those patients, we had to go to the organ responses, so renal parameters like proteinuria and creatinine to monitor those patients. So really the concept is really the same. In MGRS, if you have both measurable disease from a hematologic standpoint and organ involvement, then you should monitor both. And that's what we do now with AL amyloidosis, right? We have a set of parameters for the heme response. So we want to get them to a DFLC of less than 40 milligrams per liter. And in fact, many investigators now, like Eli Mukhtar, has even suggested a DFLC of 20 milligrams per liter. But in addition to the hematologic parameters, you have to monitor the organ responses. Now in AL amyloidosis, you have to monitor the heart response with NT-proBNP. You order the renal response with proteinuria and creatinine. And that's because of this. The monoclonal protein is not equally toxic throughout. Some monoclonal protein are much more toxic and some monoclonal protein are less toxic. And we know that in some patients, if you have an 80% reduction of the monoclonal protein, the organ starts to heal. Whereas in other patients, we have to go to 90, 99%, maybe even 100%. Because if you look at the study with MRD negativity, even with MRD negative, which in most studies are defined 10 to the minus fifth, some of those patients still have organ progression. Now, MRD negative patients have less organ progression than CR patients, and CR patients have less organ progression than VGPR. But what that tells you is that monitoring the hematologic response is not enough in patients with MGRS or MGCS. You have to monitor the organ responses as well to tell you when you can stop. Now, of course, again, in the kidney, the problem is the point of no return. How do you know that when the kidney is not going to respond anymore, there's just too much damage? And that's tough. You need your nephrology colleagues to really help with that to see if that state has been reached. If a patient doesn't have a hematologic disease to follow, then you have to just follow the organ responses. And that's what we do with the PGN-MID patients. We just follow their organ response to gauge. And it's very difficult because when you don't know the clone, you don't know if they're not responding because you didn't give them enough therapy, or did you give them the wrong therapy, or because they reached a point of no return that no therapy is going to help. So it is very difficult. We are working on different techniques to try to help with the monitoring. But at current times, it is very difficult. Now, your third question about kidney biopsies. So unfortunately, most of the diseases cannot be diagnosed any other way. There are a couple that you can, though. Obviously, AL amyloidosis, if you biopsy something else like fat or bone marrow or rectum or lip, if you get amyloid, you can infer that it's also amyloid in the kidney. The other disease that you can make the diagnosis on is light chain proximal tubulopathy. So in light chain proximal tubulopathy, they should have amino aciduria. So you can do a urine amino acid, and if the urine amino acids are elevated, then they have proximal tubulopathy. And that's a pretty specific test. So now, even at the Mayo Clinic, our urine amino acid tests have changed multiple times throughout the years. We used to do a 24-hour test. We have to pick out, and they wouldn't do the whole panel. You have to pick out 5 amino acids and they'll run the 5 amino acids. Nowadays, they do a spot urine test and they do the whole panel. And what we want to see when we do that is that we want to see multiple amino acids elevated. So not all of them have to be elevated in the urine, but you want to see multiple. And when I had to pick 5, I would pick an acidic one, a basic one, a very simple one with a benzene ring, one branch. So kind of represent the different types of amino acids. And if you see more than one elevation, then you get the diagnosis of proximal tubulopathy. Now, unfortunately, that one is the one that also has very low grade proteinuria. Most patients present with less than 2 grams of proteinuria, so it has to be a high level of suspicion. Aside from that, unfortunately, is tough because PGNMID is a renal limited disease, so we've never found it outside the kidney. MIDD, you can find it outside the kidney. It actually has the same pattern of involvement as AL amyloidosis, but the other involvements only occurs, or the occurrence increases in patients that have multiple myeloma. In the MGRS state, most of them are renal limited. And unfortunately, we haven't found a non-kidney biopsy way yet to diagnose MIDD. Same with immunotactoid, mostly renal limited. And even in the TMA, 50% of those do not have the hemolytic anemia associated with thrombotic microangiopathy. So even if your peripheral smear, your LDH and hemoglobin are normal, it doesn't rule it out as having renal TMA. C3 glomerulopathy, same thing. 50% of them have normal C3 when you make the diagnosis. So a low C3 is certainly helpful, but a normal C3 doesn't rule it out. So.
Fantastic. Thank you so much. Dr. Sindhu?
Yeah, it was great learning from you, sir. So my question is what we routinely see in our clinical practice. So when a patient with CKD comes to us and we evaluate by kidney biopsy, we find that the patient will have some immune complex glomerulonephritis. Like we have find a monoclonal immunoglobulin deposition, be it IgA kappa, IgG kappa, IgG lambda. And we fail to find any plasma cell or a lymphocyte infiltration in that. In such scenario, wherein we don't find any monoclonal gammopathy in plasma or urine and no clone that can be found out on the biopsy, how should we choose our therapy? As you know, as you already said, it should be a clone directed therapy. And in this case, we don't, it's not possible to find a clone. In such a case, is it better to start with something like daratumumab and which can actually affect both the clones, or that is my question. And if we have to change the therapy, it is when should we actually consider change of a therapy? How many cycles of therapy should we actually give?
Very good question. And it's another one that we face all the time. I don't know anyone that has a great answer for that, but I can tell you my approach. Now, in this day and age, the only disease that we really have difficulty finding the clone is the PGNMID. And so when, although we do see it in other cases, we've seen it in immunotactoid and other, but when we don't find a clone and it is not PGNMID, then I really question the renal pathologist as to whether or not did they get the diagnosis correct. I can accept that, 80 to 90% of my patients with PGNMID won't have a clone, but I cannot accept an MIDD without a clone. I cannot accept light chain proximal tubulopathy without a clone. So just bear that in mind that with certain diseases, you should find a clone. I mean, with the serum-free light chain assay now, 99% of the patients should have either a positive immunofixation or an abnormal free light chain ratio. Now, let's say it is PGNMID and we don't find a clone. I actually start with rituximab. I start with rituximab because if they respond to rituximab, the response is generally durable, meaning that with 2 to 3 cycles of rituximab, they can go into a remission. And I have patients like that. In fact, one of the patients in the daratumumab trial, she didn't fail daratumumab, but she developed a very rare side effect, which is close angle glaucoma. And apparently, this is a side effect that affects mostly women, and actually women of Asian origin. So you might see it in your country as well. But she developed eye pain within 10 minutes of the Thera infusion. We got her over to ophthalmology. Her eye intraocular pressure increased. And so she couldn't get any more. And I gave her 2 cycles of rituximab, and she's 3 years out now, and she's still in remission. So I like to start with rituximab because I find that patients who respond to rituximab seem to really respond. And then I usually switch after 2 to 3 cycles. If I don't see any renal response after that, then I switch. So from rituximab, I typically will go to a bortezomib-based therapy. Nowadays, we could get daratumumab easier. So until the study came out, it was very difficult for us to get daratumumab in MGRS patients. So we couldn't even get it. And so I would go to a bortezomib-based therapy. And with the Athen data, it really suggests that we should go with combination dara rather than mono therapy, because the response rate is so much better when you add it to something else. I know cost could be an issue, but you can certainly add. I know lenalidomide is pretty cheap in India, so Dara-Len might be a great option. The one thing with Dara is that we are seeing these patients having relapses, and they relapse within a year or so. So I don't know, obviously we have no bone marrow to show us why they're relapsing. And so I don't know the reason that they're relapsing, but we're trying to study that a little bit more. And then, of course, the worst case scenario is probably the LPL clones. They respond a little bit to the rituximab, they respond a little bit to the daratumumab, and you have no idea, some of those are inferred that, well, they responded a little bit to rituximab, they responded a little bit to daratumumab, but they don't respond to both. Maybe it's an LPL clone. And so you just have to kind of go through the deduction. But what I try to do is I try to treat one clone to where I think they should respond if it is that clone. And if they don't respond, then I switch to the next, and I try to isolate the clone so that I know which it is in the future. But yeah, it can be very tricky. And we have had a couple of PGNMID patients now progress to full-blown multiple myeloma. So these clones can eventually progress.
Thank you, sir. Dr. Shilpa Prabhu.
Yes.
So thank you for a wonderful talk. My question is, are there certain indicators where we can distinguish a category of high-risk MGRS so that we treat them differently? And do you have something in your trials which, other than the bortezomib melphalan, for these patients? I mean, newer drugs for these patients other than the daratumumab, bortezomib, and melphalan.
So there are a couple of things. We looked at using urinary exosomes in the past to identify MGUS that have more nephrotoxicity. And urinary exosome was actually very useful in detecting patients that would form AL amyloidosis, but it's a very difficult technique to isolate the urinary exosomes. The newer technique is, so the Mayo Clinic has switched platform in doing the immunofixation. We no longer do immunofixation. We use a mass spectrometer to detect light chains. What we found is that it turns out not all light chains are the same, which we knew that from before, but now we have mass spectrometry data. And it turns out that light chains that are heavily glycosylated are more likely to cause organ damage. They're more likely to cause MGRS, and they're more likely to be involved with neuropathy. So MGCS. Now it's not 100%, but it's enough that, in fact, when our lab detects a heavily glycosylated light chain, excuse me. Excuse me. When we detect one, we actually report it out in the lab report saying that this patient has a heavily glycosylated light chain and that you should look for organ damage from that light chain. So yeah, we are starting to get more clues as to which light chains are more likely to cause disease, but nothing that is commercially available yet, but hopefully soon.
Thank you. Dr. Akshay.
Thank you, sir. Thank you, sir, for the wonderful lecture. Sir, how often is doing 24-hour protein urine electrophoresis helpful after we do serum protein electrophoresis, even after doing kappa lambda light chain ratio in finding the clone? That is first question. And sir, second is, what is the ideal upfront treatment you are using for the patients with MGRS?
So with the modern immunofixation techniques and the serum-free light chains, the urine is becoming less and less helpful. I would say that in our experience, less than 5% of the patients that are negative by serum immunofixation, or now we use mass fix and the serum-free light chain, that we detect a monoclonal immunoglobulin in the urine. So there's still some, but they are extremely rare. And in fact, I do have one patient right now where she is mass fix negative in the serum, but she is immunofix positive in the urine, and we did mass fix in her urine, and we did detect the light chain. So these patients are extremely rare. Like I said, I think that, you know, less than 5% of the patients that are double negative for immunofix and free light chain will you find a monoclonal protein. Now, we do the 24-hour urine in myeloma and in amyloid because they are part of the response. So it isn't so much that they are important for diagnosis, but they are part of the response criteria. So that's why we continue to do them. Okay. And then your second question was?
The treatment therapy.
Oh, the 20-20-20. Well, you know, like I said before, if you're going to treat them like a myeloma, then you don't really have to know that they have an MGRS. The only MGRS that you really need to know is AL amyloidosis, because that one you do have to treat a little bit differently. So if you suspect that they have amyloid, you definitely want to know. And we, you know, sometimes we figure that out, like we have patients that we think it's just myeloma, and we start them on, you know, bortezomib, and they develop heart failure. And then we go back and do the test, and it turns out they're amyloid, or their kidney function drops, you know, faster than expected, even though they're starting to respond. That shouldn't happen with calcium nephropathy. So we have to we have to evaluate further. But once you start treatment for, if you're going to call them multiple myeloma, whether it's by 2020, whether it's by 2014 or by CRAB, MGRS becomes less irrelevant unless, like I said, the kidney continues to progress, and then you need to know why the kidney's progressing even though they're responding.
Thank you, sir.
Thank you. Dr. Ravi Teja.
Thank you, sir. It was a great talk. My question is, does MGRS progress rapidly to multiple myeloma than MGUS? And how often would you like to follow up these patients?
So there's only been one study out of Europe that looked at this. And in that study, the authors concluded that the MGRS patients do progress faster than MGUS patients. But the problem with that study is that they didn't define what they meant by progression. So is treatment with clone-directed therapy progression? Or did these patients actually progress to CRAB? So I read through that papers many times and I could not find what they meant by that. In our hands, we don't think so. But once you treat someone, you kind of change the clinical history, right? I mean, that's why we treat high-risk smoldering multiple myeloma now, is that we don't want them to progress. So can we say that the smoldering myeloma patients that we treat, do they progress faster or slower? Once you interfere, it's not fair to compare them to MGUS patients who are not getting treatment. So I don't know how to answer that question. Yes, maybe that they are more likely to progress, but what is the definition of progression? Certainly, we don't see a lot of our patients progressing to CRAB. Very few actually do. And so, but I think we need more studies and better definition studies to help answer that question. Now, how often do we monitor these patients after treatment? We monitor them like we monitored the AL amyloidosis. We check them so after treatment, we check them every 3 months for any recurrence of the monoclonal protein and also recurrence of the kidney disease.
Thank you. Sir, do you want to take some questions from the audience?
Sure.
Okay, sir. There's a question from Dr. Bahaduria. What is the scope of electron microscopy in the diagnosis of this entity, MGRS?
So that depends on which renal pathologist you ask. Now, if you ask the US renal pathologist, they say very important because nearly 100% of the kidney biopsies in the US have electron microscopy. However, if you ask the renal pathologist in France, they would say not very important because only about 5% of their kidney biopsies undergo electron microscopy. So electron microscopy is important in that it confirms the deposit. So sometimes we have deposits that are traced to 1+, and we don't know if they are real deposits or if they were trapped. Now, if we don't see electron dense deposits on the electron microscopy, it's hard to say that they are real deposits and not just trapped deposits. Trapping is when, when the protein is in the urine and it kind of gets stuck to the kidney, but is not actually being deposited or being taken up by the kidney. And deposited, these non-specific trapping usually have no clinical significance. And electron microscopy can help with that. Also, a lot of times where the immunofluorescent is not conclusive, we again want electron microscopy to help identify. Sometimes, immunotactoid can look like amyloid on light, and the electron microscopy would help us distinguish between the two. Fibrillary is another one. So there are 3 fibrillary entities that we deal with MGRS, and fibrillary is the one that unfortunately there's a small percentage of fibrillary that are weakly Congo red positive. And so before the discovery of DNA JB9, electron microscopy was one way to determine whether it's amyloid fibrils or fibrillary fibrils. Now with DNA JB9, you have to do the immunofluorescence test to determine if it's fibrillary or amyloidosis. So it is helpful in the right hands. I think that it is more helpful if the pathologist is not experienced in renal pathology, and because even in the United States, not every center has a dedicated renal pathologist, and so obviously the more tests to confirm the diagnosis, the better. But in experienced renal pathologists' hands, you may be able to get away with immunofluorescence and the light microscopy.
Thank you, sir. Dr. Dipankar has a question.
Yes, sir. So I have a case, sir. There is a 64-year-old gentleman who is hypertensive, diabetic, and has a previous history of coronary artery disease, which was diagnosed in like 3 years back, around 2018. At the time, he presented with anemia and a chronic kidney disease. He was diagnosed by a nephrologist as a chronic kidney disease. And seeing this CKD point of view, he was evaluated for a myeloma point of view also. So a serum protein electrophoresis was done that was showing a like an M band of 0.7 or 0.8 and a kappa or lambda light change around 150 to 200. At the time, they consulted a hematologist and a bone marrow was also done. So it showed around 8 to 10% clonal plasma cells at that time. The protein urea was like 300 or 400 milligrams per day. So at that time, he was managed by the nephrologist only. And for the time being, he was observed for the purpose of this MGUS. He was monitored on 6 monthly basis. The M protein remained stable around 0.7 and 0.8. But now in 2020, his renal function deteriorated. Initially, he was having a creatinine of 2 to 3, but now it went up to 8 and he became hemodialysis dependent. Second, anemia also worsened. So these 2 parameters worsened. He came to us for further evaluation. So again, a bone marrow was done. This time, the plasma cells increased from 10 to 15 up to 15 or 18%, like 7 or 8% plasma cells were increased, and the bone marrow showed a kappa and lambda both restrictions. So the serum protein electrophoresis, the M band was 0.9, and the SIFE, the immunofixation, showed IgG lambda plus IgA kappa. So both kappa and lambda light chains were there. So seeing the worsening of the anemia and renal dysfunction, we started on the Velcade, thalidomide, and dexamethasone therapy. And he received 6 cycles. The M protein slowly it reduced up to 0.2. Now he's 6 months on VTD therapy. So what is the role of maintenance or any role of kidney transplantation at a later date? Because kidney biopsy, which was done initially by the nephrologist, it showed diabetes related kidney injury or the 50%, more than 50% glomerulosclerosis in the kidney biopsy, which was done initially in 2018. So we thought this is mostly diabetic, but now this worsening kidney function, we cannot find out what is the cause behind it. So we had to start on the therapy. But now the M protein has decreased. So what should be the next treatment option? Should we go on maintenance? Because it is almost 80% response in the M band. So almost 80%. And is there a role of kidney transplantation?
So a couple of things. One is that whenever I hear diabetic kidney disease in patients with monoclonal gammopathy, you have to think of MIDD, because the MIDD, on light microscopy, it can look identical to diabetes. And so this is one where immunofluorescence and electron microscopy might be helpful to make sure that there's no deposits. Now, assuming that this is, so first scenario is, this is diabetic nephropathy, and he progressed. And this person has a biclonal gammopathy, but no CRAB. And of course, do we know, like you said that there's about 17-18% plasma cells, but do we know what portion is kappa and what portion is the lambda?
Actually, the kappa lambda both are present, but clonality could not be established because both kappa and lambda chains are there. So immunostaining with both, but no clonality is established.
And what about his free light chains? What
So
are they
it's
now?
like 150 to 200, between 150 to 200, both kappa and lambda. It's initially was also 150 to 200. Now it's also 150 to 200 only. And after this, like 6 months of therapy, it has reduced like 30 or 40 less than that, like initially.
And equally, they've reduced equally?
Yes, sir. The ratio is around 2.2 kappa lambda.
Yeah. So, I mean, this, if he has no CRAB, this patient might be a biclonal gammopathy and maybe 2 MGUSs, together. So the issue is, if the kidney disease was diabetic nephropathy, then is kidney transplant viable? It should be. I mean, there's no evidence that the monoclonal protein is injuring the kidney. Now, in terms of patients with MGUS going to kidney transplant, and does that increase their risk of progression? We have had multiple studies now showing what happens to patients with MGUS that undergo kidney transplant. And it seems that the rate of progression to myeloma is not increased as long as they really were MGUS. We have a few patients that were probably right on the edge of smoldering multiple myeloma, and they did, the ones that progressed early were mostly patients with smoldering multiple myeloma that probably may have been already multiple myeloma by the time they progressed. But in patients with regular MGUS, the rate of progression doesn't seem to be any faster than normal patients. Now, if this is MIDD though, then you really have to treat to probably more of a CR before you do the kidney transplant. MIDD is one of those, it's not super fast. The median time to recurrence is about 1.5 to 2 years, but it is 90% recurrence rate if the monoclonal protein is still present. So the scenario is a little bit different if this is an MGRS. If it's not, then you're dealing with a biclonal gammopathy, and at least from the immunosuppression standpoint, it doesn't seem to hasten the progression of the MGUSs. But I guess the real question is, what is the natural history of his MGUS? Because the bone marrow biopsy percentage doubled in a few years. So is he already on the trajectory course that he's going to progress to myeloma?
So, like we should go for a maintenance therapy, or we should continue the same treatment like a Velcade, Thalix, Dexona?
So if they are true MGUS, I probably wait until they progress. You know, we have done maintenance therapy in patients who underwent kidney transplant, but you always worry that you're going to over immunosuppress them. And especially in the era of COVID, we know that 30% of patients who have kidney transplant on immunosuppression don't develop adequate titers. And then you add on the myeloma therapy, which will drop them even more. In that case, since they are MGUSs, technically they are MGUSs, I would probably wait until they progress a little bit more before I reinitiate therapy. And then you'll get them through the first year of kidney transplant, which has the highest immunosuppression anyway, before you add on other agents. Also remember that there have been rejections reported in patients with solid organ transplant that use IMiDs. The circumstances is always a little tricky in that usually the standard procedure is to reduce immunosuppression when we add anti-neoplastic agents. So was the rejection due to us reducing the immunosuppression, or was it a true, was it a property of the anti-neoplastic that caused the rejection? Is hard to know. I know that we looked at our series, and at the Mayo Clinic, the only patient that had rejection was one that we did reduce the immunosuppression when we added the IMiD. So in patients that we don't reduce immunosuppression, they stay on triple immunosuppression, they haven't had a rejection. But our numbers are very low, so we don't know if that's the truth or it's just that we're lucky.
So, like from the nephrology point of view, they are asking then, can we transplant the patient? So, like in this case,
so what were the time frame between the biopsies?
So 3 years almost.
So in 3 years he doubled. So he has 2 clones that are doubling, but they are very responsive to therapy. I would think that they and both are equally responsive. So it's not like you have one clone that didn't get touched with BTD and the other one is reduced by 90%. I say that the risk isn't very high. I think that it would be reasonable if there's no other thing going on, unless the next marrow you do and he's right back at 20%. I think this would be a reasonable patient to go ahead.
Thank you, Dr. Dipankar. Are there any more questions?
So can I take liberty of asking one simple question?
One last question.
Yes, sir. Sir, I would just like to ask that in patients with MGUS who are detected to have a C3 glomerulopathy or TMA, like in their kidney biopsies, so do we treat the monoclonal protein in the blood because they are not having any lesions in the kidney? So how do we treat MGRS in these patients in case of C3 glomerulopathy or a TMA? And is there any role of plasma exchange in patients of MGRS who have TMA on their kidney renal biopsy?
So the TMA is probably one of the least known MGRS. We made, the association was only made within the last 10 years. So I can tell you what has been the experience in our hands. We published a small case series, an international series of patients who their presenting symptom for the monoclonal gammopathy was TMA. So we had patients with MGUS, smoldering multiple myeloma, myeloma, and Waldenstrom. In these patients, treatment of the underlying disorders resolved the TMA. So you have to treat the underlying disorders. Now, we've also have a number of patients that present to Mayo Clinic where they presented with TMA, and then during the workup, they had a monoclonal gammopathy. I can tell you that in these patients, the response to eculizumab was poor. So it was less than 50% responded to eculizumab, suggesting that the mechanism of action is different in these patients with the monoclonal protein. We have so far treated one patient to CR. Actually, he's MRD negative. So he went through induction, then went through stem cell transplant, and he's on daratumumab maintenance. And we were able to give him a kidney transplant once he was MRD negative. And so far he's doing well. Now, for insurance sake, we gave him 2 doses of eculizumab right after the kidney transplant. But we also tested his alternative complement pathway, and they were not active before we gave the eculizumab. So after we eradicated his monoclonal protein, his alternative complement pathway has become negative. The one thing that we didn't do was we didn't do an alternative pathway before we started him on chemotherapy. So his lack of response to eculizumab was based on platelet count and LDH. We didn't have an alternative pathway to say that it wasn't inhibited. So that's the only, and we have several patients like that, where we give them, nowadays, if in the United States, if they come in with TMA, if we rule out TTP, we're going to give them eculizumab, and these patients, less than half of them will respond to eculizumab.
Thank you, sir.
Thank you. Before I hand over to Adley, Mr. Prashant Agarwal, who's going to show some slides for vote of thanks on my behalf, on behalf of Mumbai Hematology Group, all the faculty from India that was present here, and a huge number of delegates who have logged in from various countries. I'm extremely grateful to you, sir, Dr. Nelson. 2 hours of your time we have consumed, your lecture, and then very patiently you have answered questions and to the satisfaction of everybody. They were tricky questions. There are no simple answers, but you handled them with all your 20, 30, 40 years of experience, and you taught us what this subject is like. Grateful to you for sparing your morning today and 2 hours with us. You have made a difference, and I think patients will benefit. Thank you, sir. Now I hand over to Prashant for the official vote.
Yeah. Thank you, sir. And it was a wonderful presentation by Dr. and Professor Nelson. It was a wonderful knowledge sharing evening, in fact. And on the behalf of Adley, I would like to thank you. And I would like to thank.
Hello.
Yeah.
Put your screen on a slideshow mode, sir. Full screen.
Yeah, just a minute. Yeah, now it's okay?
Yes.
Yeah, and on the behalf of Adley, I would like to thank Professor Nelson, as well as I would like to thank Lieutenant Colonel Dr. Uday, Dr. Darshana, Dr. Shilpa Gupta, Dr. Shilpa Prabhu, Dr. Deepankar, Dr. Saurabh Kumar Mishra, Dr. Vinu, Dr. C.S.K. Prakash, Dr. Rintu Sharma, Dr. Aniket, Dr. Akshay, Dr. Kunal, Dr. Sindhu, and Dr. Banda, Ravi. But at the end of the day, I would like to give the special thanks to Dr. M.B. Agrawal for conducting series of webinars and being instrumental in disseminating medical knowledge for healthier tomorrow. Adley feels privileged to be a part of this endeavor, sir. We at Adley very well understand that every moment of life is precious for the cancer patients. And as a responsible oncology company, we accelerate their hopes by providing high quality and cost effective high-end oncology drugs. That's why Adley is becoming the fastest growing oncology company in India. Adley is having own state-of-art manufacturing facility in India and Uzbekistan. It has a presence in major corporate and the government hospitals. Adley focus on new product development and bring cost-effective medicines. Adley emphasize on patients first approach. So we are expanding our wings across the globes like Southeast Asia, then Africa, Latin America, China, CIS, to name a few. I am happy to announce that Adley is going to Adley has developed its in-house azacitidine oral and launching it shortly. Now, not only this, but we are also coming up with carfilzomib injection at the cost-effective price. So, Adley works on guiding principle of patient's first approach. By keeping this in mind, our R&D team work on the patient compliance and develop NDDS formulations like docRT, gemcitabine R2, and albumin-bound paclitaxel. Adley work for the patient education by conducting various campaigns to maintain the quality and provide cost-effective medicines. We produce API for our own formulations. At the last but not the least, Adley is having easy and fast patient assistance program for all the needy patients. So I end my presentation here with these words that we are open for any drug support for all the needy patients. And I just end with the saying that it was a very wonderful evening, wonderful presentation by Dr. Nelson. And I thank you all the participants, all the attendees, and have a nice day. Good night, sir.
Thank you, Krishna. Again, thank you, sir, for giving this lecture.
I just want to thank Dr. Agrawal for this wonderful invitation to talk about MGRS. And actually, I want to thank all the people that ask questions because, it's your questions that drive us to look for answers. And without these great questions, we would not know to look for other things to answer. So thank you very much for this wonderful discussion. And again, it was a great opportunity for me to speak to all of you.
Thank you, sir. And I'm sure you will oblige us in future as well. Thank you and bye-bye, sir. Have a wonderful day ahead.
You too. Have a wonderful evening, everyone. Thank you.
Bye-bye.
Bye-bye.